Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. On this episode, I will discuss what is probably the most requested topic I have had so far, which is lesions of the mandible and maxilla. I have received repeated requests to produce an episode on this topic, and for all of those who have requested this topic and for the rest of you, I hope this will be helpful. As a quick reminder, you can follow at RadRev Podcast on Twitter and Instagram to find near-daily tips on high-yield physics facts, which I am at least currently posting there. If you have a topic you would like me to discuss on this podcast that I have not yet covered, please let me know and I will do the best I can to produce an episode covering that topic. I appreciate each of you for listening to this podcast. Without further ado, let's get into the questions and answers for this episode. But before we get to the first question, let me just say that the number of lesions of the mandible and maxilla are extensive. Therefore, this episode will focus on many of the most common lesions of the mandible and maxilla, as these common lesions are also the lesions I believe are most likely to be tested on radiology board examinations, with the notable exception of the neuroradiology subspecialty exam, which is beyond the scope of this episode. My advice is to not get lost in the weeds when it comes to lesions of the mandible and maxilla, and to first master the most common lesions before you venture into uncommon pathology. First question: what are two of the most common odontogenic tumors? Perhaps the two most common odontogenic tumors are odontomas and ameloblastomas. That is AMELO, ameloblastoma. An odontoma, 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 is the most common odontogenic tumor of the mandible, followed by ameloblastoma. Next question: what is a common association with an odontoma? Odontomas are associated with an unerupted tooth in approximately 50% of cases. Note also that odontomas have a Gardner syndrome association. As a reminder, Gardner syndrome is a familial polyposis syndrome associated with things like osteoma, desmoid tumor, fibromatoses, and odontomas. Gardner syndrome is a high-yield topic for the radiology board exams, so if this is a topic you have not yet covered or mastered, remember the association between Gardner syndrome and familial polyposis, as well as osteomas, desmoid tumors, fibromatoses, and importantly for this episode, odontomas. Next question: what are common imaging features of an odontoma? Common imaging features of an odontoma include a lucent lesion of the mandible or maxilla that over time shows calcifications that coalesce to form a dense lesion with a lucent rim. A complex odontoma may show irregular calcifications with no distinct tooth, and a compound odontoma may show a lesion with tooth-like components. That may or may not be beyond the scope of what you need to know for the ABR core exam. I would at least be aware of the presence of an odontoma, that it is a distinct entity. I would also be aware of the Gardner syndrome association. I would be aware of the association with an uninterrupted tooth. And I would remember that an odontoma commonly looks like a lucent lesion of the mandible or maxilla that over time shows calcifications that typically coalesce to form a dense lesion with a lucent rim. Go ahead and look up some images of odontomas online or in your favorite corresponding textbook, and let's move on to the next question. Odontomas and ameloblastomas arise most commonly in which decade of life, respectively? First of all, odontomas arise most commonly in the second decade of life. Ameloblastomas arise slightly later, most commonly in the third to fifth decades of life. Next question. What is the most common location for an ameloblastoma? Ameloblastomas most classically arise near the angle of the mandible, but ameloblastomas can less commonly be seen elsewhere along the mandible or maxilla. Next, what are common imaging features of an ameloblastoma? Most ameloblastomas show a multicystic or soap bubble appearance, which appears as an expansile cystic lesion with well-defined margins. However, some ameloblastomas may be unilocular instead of multicystic or soap bubble in appearance. Ameloblastomas are often locally aggressive, so look for additional features such as tooth resorption and cortical erosion through the bone into adjacent tissues. Less commonly, an ameloblastoma may show a unicystic appearance, as I mentioned, appearing similar to other lesions to include a dentigerous cyst. On MRI, an ameloblastoma may show solid papillary projections within the lesion that show avid enhancement, which can be helpful for diagnosis. Less commonly, ameloblastomas may be malignant and show evidence of metastatic disease on imaging. Signs of potential malignant degeneration include cortical destruction, extraosseous extension, aggressive growth, and large solid components. Next question. What is the common imaging appearance of a dentigerous cyst on imaging? A dentigerous cyst, first of all, is also sometimes termed a follicular cyst. So, at least historically, dentigerous cyst and follicular cyst have been used interchangeably. The classic appearance of a dentigerous cyst is a unilocular lucent lesion surrounding the crown of an impacted or non-erupted tooth in the mandible. It is said that imaging showing the crown of a tooth projecting into the cystic space is essentially pathognomonic of a dentigerous cyst. On CT, fluid within the cyst cavity is often water density. On MRI, dentigerous cysts follow water or CSF signal, which means low T1 and very bright T2 signal with no internal enhancement, but possible thin peripheral enhancement. So you can go ahead and compare and contrast that with the imaging features of an ameloblastoma that I just included on the prior question. Also, remember that if you want to review this in writing, you can download the free study guide on this topic on my website, theradiologyreview.com. That is freely available to anyone who would like to download that. Next, what are some basic differences between a periapical cyst and a dentigerous cyst? First of all, periapical cysts are more common than dentigerous cysts. Dentigerous cysts are often associated with the crown of an impacted or unerupted tooth, and a periapical cyst is often associated with the roots of a tooth. A dentigerous cyst is related to fluid accumulation around an unerupted tooth, whereas a periapical cyst is often the result of a dental infection, and an associated dental cavity may be seen. Both of these often appear as a unilocular lucent lesion. Unlike a periapical cyst, a dentigerous cyst can become very large. Dentigerous cysts have a low risk of transformation into an ameloblastoma. Next, what are typical features of an odontogenic Corrado cyst? Odontogenic keratocysts are classically destructive, multilocular lesions centered about the ramus or body of the mandible. Unlike a dentigerous cyst, an odontogenic keratocyst can erode through the cortex of the mandible and may have daughter cysts within the surrounding bone. If you see multiple odontogenic keratocysts, basal cell nevus syndrome can be considered. Again, I want to impress the importance of remembering these syndromic associations when they do exist for these dental lesions, because at least on board exam preparation questions, it is common to have something like a mandibular lesion as a secondary finding of something like basal cell nevus syndrome to help clue you in, first of all, that you are being asked about a syndrome rather than an individual lesion, and simply that these questions are easy to write and often help separate those who have a deep knowledge of core exam topics as opposed to those who do not. So in the setting of an odontogenic keratocyst, I would try to remember an association with basal cell nevus syndrome. And let's move on. What are classic features of a juvenile ossifying fibroma? A juvenile ossifying fibroma is a lesion most often seen in boys under the age of something like 15 years of age. A juvenile ossifying fibroma is an aggressive tumor that can be seen in the mandible or paranasal sinuses. A key feature is rapid growth. Next, if a patient with multiple myeloma of the mandible or another mandibular malignancy presents with numbness of the chin, what is a potential etiology for this symptom? The answer I am looking for is malignant involvement of the inferior alveolar nerve, as this can cause chin numbness, that's CHIN, chin numbness in the setting of a mandibular malignancy. Next, what are some of the most common primary tumors that may metastasize to the mandible? Some of the most common tumors that can metastasize to the mandible include breast, lung, and renal primary malignancies. The most common site for metastatic disease of the mandible is the posterior body and angle of the mandible, as these have a more robust blood supply compared to other areas of the mandible. If you see a sclerotic metastasis to the mandible in a genetic male, consider prostate cancer as well. Also remember that multiple myeloma may show involvement of the mandible. Next, what is more common, metastatic disease to the mandible or metastatic disease to the maxilla? The answer I am looking for is that metastatic disease to the mandible is much more common than metastatic disease to the maxilla, something like 4 times more common, so just keep that in mind. Next, multiple osteomas in the mandible have a classic association with what syndrome? The answer I am looking for here is Gardner syndrome, which again is a familial colonic polyposis syndrome. As a reminder, I also said that odontomas have a Gardner syndrome association, so I would in general remember Gardner syndrome can be associated with lesions of the mandible and maxilla and include things like an odontoma as well as multiple osteomas in the mandible. Next, osteonecrosis of the jaw is associated with what common therapy? This is a high-yield question, in my opinion, for the ABR core examination, and the answer I am looking for is bisphosphonate use. Bisphosphonate use has a classic association with osteonecrosis of the jaw. This results in osseous destruction of the mandible more commonly than maxilla and may have exposed bone as a result. Other medications may also be associated with osteonecrosis of the jaw, and this includes medications like denosumab, which is a RANK ligand inhibitor, RANKL inhibitor, as well as tyrosine kinase, mTOR, and VEGF inhibitors. Next, if you see pronounced increased uptake diffusely involving the skull and mandible on a bone scan, what entity should you first consider? Again, pronounced increased uptake diffusely involving the skull and mandible on a bone scan, what entity should you first consider? The answer I am looking for here is hyperparathyroidism. Hyperparathyroidism is most classic on board exams for diffuse, intense skull and mandibular uptake, although this can also be seen with other metabolic bone disease entities. Next question. If you only see diffuse bone scan uptake through the mandible, but not the skull, what entity is most likely on board exams? I think in the setting of isolated diffuse bone scan uptake in the mandible but not the skull, I would consider the possibility of Paget's disease. Some have termed this the, quote, black beard sign, end quote. If you are looking at monoostotic Paget's disease, the mandible could be the only site of uptake. Other classic areas of uptake in the setting of polyostotic Paget's disease include the pelvis and the femurs. Next and final question for this episode. If instead of diffuse uptake, only a more focal portion of the mandible shows uptake on a bone scan, what are top differential considerations? First of all, I would think of the possibility of fibrous dysplasia of the mandible, as this is one common cause of bone scan uptake that involves only a portion of the mandible. Dental disease may also show focal mandibular uptake due to inflammation with active bone remodeling. Metastatic disease may also be considered, particularly if other sites of suspicious uptake are also noted on the bone scan. That concludes this episode. I hope that this will be helpful for many of you. If you want to review these questions and answers in written form, please go to my website, theradiologyreview.com, where you can download a free study guide on this and the majority of other episodes that I have previously covered on this podcast. I also am including a link for a fantastic radiographics article that covers additional details and great images of dental and mandibular lesions that you can also find at the end of the study guide on my website, theradiologyreview.com. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.